Okay, let's go on to case 3. So this is a 44-year-old male who has a 2-year history of psoriatic arthritis that had been superimposed on a 12-year history of psoriasis. His psoriasis had been managed over the years with topical agents or light therapy, but once his articular disease developed, then he was treated initially with methotrexate. Then etanercept was added after 6 months with inadequate response to methotrexate. So he presents to the clinic now on etanercept and with some methotrexate background, who with flaring pain in his left first MTP joint over the past week and swelling of the whole left foot. He's also had, he will describe as he's gritting his teeth, describing his terrible MTP pain. By the way, Doc, I'm having more psoriasis and more articular pain in other joints like my hands and wrists than I had before. So I'm a little worried that etanercept is losing its grip, and furthermore, I've been bothered by some lower back and neck pain that's been bothering me a lot in the morning, and I feel like the Tin Man when I'm getting up out of bed. So, what's going on here? We've got this major problem of the foot pain, but he's also kind of losing benefit with etanercept in the other domains. So basically, the patient has gone away that day, but then came back the next day, uninvited. They didn't even make an appointment. They just showed up and said, I can't bear this anymore. The pain in the first MTP is really bad. So we did go ahead and inject steroid at that time. And we're still awaiting some laboratory data as well as imaging data. So here we have, we got the joint injected. We decided to go ahead and think of this as gout. And indeed, looking at the x-ray, look at that first MTP joint, pretty osteolytic. Looks like he's been having some crystal destruction going on there for some time. It's not acute. We've got him on some colchicine, 0.6 milligrams twice a day. He got his steroid injection. And then we see that he has an elevated uric acid level. His CRP is 6.5, which is elevated. SED rate is elevated at 34. He's also got some elevation of his LFTs, probably because he's a bit obese. And he's got a slightly elevated creatinine level. All of these consistent with a PsA patient with some metabolic syndrome, gout. I mean, he's got lots of comorbidities going on. Okay, so at this point, what would we do? Let's look at some choices. This is a guy who's got more than one thing going on. He's got some gout, it looks like, but he also may have some flare of his underlying psoriatic arthritis. So would you start allopurinol after the gout flared, settled down? Would you order, and we've got some X-ray imaging back, which is pretty unremarkable, except for some degenerative change in the spine. Would you order an MRI scan of the pelvis? Would you order an MRI spine of the spine aspects to further investigate some of his back symptomatology that he's mentioning, along with his other peripheral articular disease being flared up? Would you order and wait on an HLA-B27 to come back? And would you be thinking about switching biologics? So let's see what the people here are choosing. So it looks like you would start allopurinol after gout flare settles down. I think that's absolutely correct. You're curious about the B27 and MRI scans before making your final decision on adjusting immunomodulatory medicines. I think that's absolutely correct. We're going to get there, but it's important in our choice of therapies to know whether or not he's got some immunologic inflammation going on in the spine or not. So here is his X-ray, which on the left-hand side to my eye, which is on your view, looking towards the right of the image, is looking pretty normal. But the right-hand SI joint, I'm a little bit mixed on. Is there a little bit of periarticular sclerosis there or narrowing? It's just hard to tell. So I'd probably call that a grade 1 or 0. Lumbar spine looks pretty darn good. Surprising, even for a 44-year-old. And his cervical spine looks pretty good as well. Ah. Look at that pelvis MRI scan. He's got some active light up in the bone adjacent to the joint. So yeah, looks like there is some disease going on, or some inflammation going on there. So this gives us some idea that maybe he's developed some axial aspect to his PsA. He's had a couple of years of peripheral articular involvement, and interestingly, with PsA patients, they don't tend to get their axial disease right from the get-go of their psoriatic arthritis. It often comes up over time. We don't know exactly how frequently this occurs. In early stage PsA, the range there is noted as 5 to 28%, and long-standing PsA, 25 to 70%. The number that I throw out is 40 to 50% overall, but that's an average. And probably it's underdiagnosed, because we're looking at people that are in their 40s, 50s, even 60s. The primary doc or the orthopedist has gotten the plain lumbar films and they show some degenerative change, and that's where we leave it. We don't really get an MRI scan to look for evidence of light up at the syndesmophyte phyte formation. And so we really don't know the true prevalence. Here's a study that was done in what was then called the Corona Registry. It's now called the Core Evitas Registry of PsA and spondyloarthritis. And we're looking at 192 patients where the investigator thinks that they have axial PsA, and 1,338 patients where it's pretty clear they don't have axial PsA. And so we're asking the question, so what? So this patient has some back pain. We'll treat it with something that we know works for ankylosing spondylitis. And then we look at these other factors. And look at this. Patients with axial disease, they all have worse disease in other domains as well. They have more tender joints. They have more enthesitis. They even have more skin disease than patients without axial disease. They're less likely to achieve minimal disease activity. That's in the middle of the table there. Interesting. So something about having axial PsA makes their overall disease characteristics worse. So this is a patient group we want to pay attention to. Here's data from Daphne Gladman's cohort in Toronto, looking at 1,354 patients with psoriatic arthritis, and finding the frequency of at least unilateral grade 2 sacroiliitis on X-ray being present in 45% of that patient population, and fulfilling New York ankylosing spondylitis criteria in 35% of that population. So one of the things that we're currently doing is the organization known as GRAPPA, Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, and the ASAS organizations are doing a collaborative study where we're going to try to come up with a classification criteria for axial PsA. And one of the challenges that we have is, what do we do about the patients who may have axial PsA who may not light up on MRI scans? And that's I'm just throwing that out there as one of our challenges. So we're based on our time constraints. We're just going to plow ahead. But what we've defined here is a guy who's got psoriasis, PsA peripherally, PsA axially, and gout. So he's got a lot going on, and we've got multiple treatment fronts that we're doing. And then the question is, what would we switch this patient's treatment to? And let's explore that in our next few slides. So here we come back to the GRAPPA treatment schema, and we see, based on, as I mentioned earlier, the data from ankylosing spondylitis trials with TNF inhibitors, IL-17 inhibitors, and JAK inhibitors, that we would consider them to be effective in axial PsA. The only trial, so this is just summarizing what I've just said about the TNF inhibitors. And then here is data on axial disease with ustekinumab and guselkumab and risankizumab. So we've had a trial with ustekinumab, an IL-12/23 inhibitor, in ankylosing spondylitis that did not show any difference from placebo in ankylosing spondylitis, even though it's had good results in the rest of psoriatic arthritis in the Summit trials. Risankizumab, a small trial, phase 2, ankylosing spondylitis, no effect, no comparison, no differentiation from placebo. Then we come to this fascinating sort of look-see at the data from the 2 phase 3 trials with guselkumab. They asked the investigators, who has in your population that you're enrolling in this study axial disease, in your opinion? And furthermore, does that patient with axial symptomatology have evidence of sacroiliitis on X-ray or MRI scan? So they found that 30% of the patients, roughly 1,000 patients in these 2 studies, had evidence of axial involvement as per those 2 criteria: axial symptoms and that were significant, greater than 4 on a scale of 10, and who had evidence of sacroiliac changes consistent with a history of sacroiliitis. And what happened? Well, we see that the various measures we use even in ankylosing spondylitis trials, such as the achieving BASDI 50, clinically important improvement in ASDAS measure, inactive disease even in ASDAS, were all clearly differentiated from placebo in the 2 different dose arms of guselkumab. But I just got finished telling you that another IL-23 agent failed in ankylosing spondylitis, and an IL-12/23 agent failed in ankylosing spondylitis. So what gives? So this raises the question, is there an immunophenotypic difference between ankylosing spondylitis and axial PsA, such that a patient being treated with a drug that otherwise works in the rest of the domains of PsA, such as an IL-23 inhibitor, may work in the spine of axial PsA patients? There has been 1 trial with secukinumab conducted as a phase 3b study in patients with axial PsA, which is very illustrative of the efficacy of secukinumab in that disease. And then there has been some look-see with ixekizumab looking at BASDI improvement in patients in their phase 3 PsA program. One thing I want to note about the secukinumab trial in axial PsA, here are the ASAS-20 responses. Clearly, it shows that it benefits. And then here we see on the right-hand side the spine scores. But one of the things that I should mention is that in this trial, 40% of the patients in the trial did not light up on MRI scans of the spine or sacroiliac joints, yet they fell in the same degree of improvement. So this is the challenge that we've got in our practices, is how to define whether the patient in front of us has axial PsA even without the objective MRI findings. We know that with the JAK inhibitors, they've recently shown efficacy in phase 3 ankylosing spondylitis and now are approved in treating ankylosing spondylitis, and we extrapolate from this to axial PsA.